Welcome to the deep dive. Today we're tackling asthma. It's super common, but actually quite complex when you dig into it.
Absolutely. Lots of detail.
Right. So our mission today is simple. Pull out the absolute key info on asthma from our notes, make it clear, make it exam ready for you, the learner.
Yep. Cut through the noise, get to the essentials.
Exactly. No overload, just the must-knows. So let's start right at the beginning. What exactly is asthma?
Okay, so think of three core things happening in the airways. First, there's inflammation. The tubes get swollen, irritated.
Inflammation, okay.
Second, bronchial hyperresponsiveness. Basically, the airways get extra twitchy, prone to spasm.
Twitchy, got it.
And third, that leads to airflow obstruction, makes it hard to breathe out.
Yeah.
But, and this is crucial, it's usually reversible.
So inflammation, twitchiness, and blockage. But a blockage that can clear up. Like swollen pipes that spasm shut but then open again.
That's a pretty good analogy, yeah. Captures the main ideas.
Okay, and what sort of things set this off, the triggers?
Oh, loads of things. Cold air is a common one. Exercise, too.
Right.
Then you've got allergens, pollen, dust mites, animal dander, that sort of thing. Also, some meds like aspirin or certain anti-inflammatories, and viral infections like colds.
Quite a range then. So those are the triggers, but what's the underlying cause? Why do some people get this?
Well, the honest answer is we don't know the exact cause fully. It seems to be a mix, you know, genes and environment interacting.
Nature and nurture again?
Pretty much. It's complex.
So on the environment side, what factors are we talking about?
Allergens are definitely significant. Respiratory infections, especially when you're very young. And air pollution is increasingly recognized as a big factor.
And are there specific things that make someone more likely to develop asthma? Risk factors?
Yes, definitely. There's a clear list. A personal history of atopy, that's other allergic conditions like eczema or hay fever. That's a big one.
Okay.
Family history, too. If your parents or siblings have asthma or hay fever, your risk goes up. That's the genetic link.
Makes sense.
Then things like inner city living, socioeconomic deprivation seem to play a role. Obesity is another factor.
Right.
Being born prematurely or with a low birth weight, those early childhood viral infections we mentioned. Exposure to tobacco smoke is a major one, and that includes if the mother smoked during pregnancy. Really important.
Wow, yeah.
And interestingly, some evidence suggests early exposure to broad-spectrum antibiotics might also increase risk.
That is interesting. Are there any factors that might sort of protect against it?
Yeah, there's some research, though it's not all definitive. Vaginal birth compared to C-section might offer some protection,
Okay.
having more siblings. Growing up in a farming environment that links into the hygiene hypothesis idea, maybe?
Wow, hygiene hypothesis.
Though it's still debated. And the evidence around breastfeeding being protective, it's actually a bit uncertain now based on more recent studies.
Right. So summing up the cause bit, genes plus environment, clear risk factors, some possible protective ones. Let's revisit the mechanism. What's happening physiologically?
So it boils down to that airway inflammation we mentioned. That chronic inflammation makes the airways narrow and hypersensitive, really reactive.
Okay.
And the result of that is the recurring symptoms, the wheezing, the coughing, the breathlessness that people experience.
Got it. Now, if someone comes in with those symptoms, wheezing, shortness of breath, how do you know it's asthma and not, well, something else? What are the lookalikes?
Great question. Differential diagnosis is key. And it varies a bit between kids and adults.
Okay.
So in children, you might think about bronchiolitis, especially in infants. Cystic fibrosis, maybe congenital airway problems they were born with. Vocal cord dysfunction can mimic it. Reflux GERD, an inhaled foreign body, obviously. Postnasal drip causing cough. Sometimes even things like bronchiectasis or TB, though less common.
Lots to consider in kids. What about adults?
In adults, the big one is COPD, chronic obstructive pulmonary disease. There's also an overlap syndrome, asthma-COPD overlap.
Right.
Heart failure can cause breathlessness, coronary heart disease, even malignancy, unfortunately. Reflux again, vocal cord dysfunction again. And then other lung conditions, pulmonary fibrosis, interstitial lung disease, pulmonary embolism, a blood clot. TB again.
So really important not to just jump to the asthma conclusion.
Absolutely. You have to rule out these other possibilities.
Okay. We said asthma is common. Just how common are we talking, say, in the UK? Any stats?
Yeah, the numbers are pretty significant. Around 5.4 million people in the UK get treatment for asthma.
Wow.
That works out as roughly 1 in 11 children and 1 in 12 adults. It's actually the most common long-term condition in childhood.
The most common. Okay.
And the cost is huge, about £1 billion a year for the NHS.
$1 billion.
Yeah. And an interesting link, the rise in asthma and allergies seems to track with that shift from rural to urban living and industrialization.
Fascinating.
Also, adult onset asthma is often not allergy related, tends to be more severe and has a lower chance of going away. And it can be particularly serious in the elderly.
Good points to remember. So clinically, what are the classic signs and symptoms you'd be looking for?
Well, the typical ones are wheezing, that whistling sound when breathing out, shortness of breath, chest tightness like a band around the chest, and a cough.
Okay.
That cough is often worse at night or first thing in the morning. And symptoms often flare up with those triggers we talked about: exercise, colds, allergens.
And putting it all together for a diagnosis, what's the process?
It really relies heavily on the patient's history, the pattern of symptoms, the triggers. Then objective tests like spirometry are crucial.
Spirometry, lung function tests.
Exactly. And the clinical examination, especially listening to the chest between attacks, though it might be normal then.
Are there specific things in an adult's history that make asthma seem more likely?
Yes, several features increase the probability. Having more than one of those key symptoms, wheeze, breathlessness, tightness, cough,
Right.
symptoms being worse at night or early morning, triggering by exercise, allergens, cold air, symptoms starting after taking aspirin or beta blockers, a personal history of atopy, a family history of asthma or atopy, finding widespread wheeze when listening to the chest, or having unexplained low FEV1, that's a spirometry measure, or low peak flow, or unexplained high levels of eosinophils, a type of white blood cell in the blood.
Lots of pointers there. What about the physical examination itself? What are you checking?
We check basics like pulse rate, respiratory rate, oxygen saturation. We look at how fast they're breathing. Are they using extra neck muscles to breathe? Any signs of effort? Listen to the chest for wheeze, which we call bronchi. Check the position of the windpipe. Maybe tap on the chest percussion to check for abnormalities, though often it's normal.
Okay. Once you suspect asthma, how do you gauge how bad it is right now, like during an attack? Severity.
We classify severity into moderate, severe, and life-threatening. We use objective measures.
Right, like a scale.
Exactly. We look at peak expiratory flow rate compared to their predicted or best. For moderate, PEFR is usually 50–75% of predicted. They can probably still talk in sentences. Breathing rate and pulse aren't excessively high. SATs are usually okay, above 92%.
Okay, moderate, then severe.
For severe, PEFR drops, typically 33–50%. They might struggle to complete sentences, maybe only phrases. Respiratory rate goes up, often over 25 breaths per minute. Pulse is usually over 110.
Right, definitely worse.
And then life-threatening is the most serious. PDFR is very low, less than 33%. The patient might be confused, exhausted, drowsy. They might have a silent chest where there's not enough air moving to even wheeze. Oxygen sats will be low, under 92%. Maybe cyanosis, bluish skin. It's an emergency.
Really crucial distinctions for immediate management.
Okay.
So confirming the diagnosis, what tests are typically used?
The main category is pulmonary function testing. Spirometry is key here.
Spirometry again.
Yep. We look for obstruction, so a reduced ratio of FEV1 to FVC, usually less than 0.7, suggests obstruction. We also look at FEV1 as a percentage of predicted to gauge severity. And the big one for asthma is the reversibility test. We give a bronchodilator, like salbutamol, and see if the FEV1 improves significantly, usually by 12% or more, and at least 200 milliliter absolute increase. That strongly suggests asthma.
Reversibility. Key finding.
Definitely. Sometimes, if spirometry is normal but you still suspect it, a bronchoprovocation test might be done using something like methacholine to see if the airways are hyperresponsive.
Okay. What about peak flow?
Peak expiratory flow, or PEF. It's simpler than spirometry, often used for monitoring. On its own for diagnosis, it's less reliable. But seeing a PEF lower than predicted, or especially if it improves by more than 20% after a bronchodilator, that's suggestive.
Right. Any other tests?
Lab tests might show high eosinophils in the blood, especially in allergic asthma. Imaging. A chest x-ray is usually normal in asthma, but might be done to rule out other things.
Okay.
And allergy tests like skin prick tests or blood tests for specific IgE antibodies can help identify triggers if it seems like allergic asthma.
Got it. Now, thinking about those severe attacks, the emergencies, what are the immediate red flags?
You're looking for signs of severe exacerbation. Very rapid breathing, say over 30 per minute. Tachycardia, pulse over 120, obvious use of accessory muscles in the neck and shoulders to breathe, sweating, extreme difficulty breathing, gasping, sometimes something called pulsus paradoxus, a big drop in blood pressure when breathing in.
And immediate management in the emergency department.
Two main goals. One, resolve the airway obstruction. That means high-dose inhaled bronchodilators, often via a nebulizer, plus systemic corticosteroids like prednisone tablets or IV hydrocortisone.
Okay, open the airways, reduce inflammation.
Exactly. Goal 2, correct the hypoxemia, the low oxygen. So supplemental oxygen is given to keep SATs usually above 94%. Monitoring is vital, PEF, SATs, heart rate, respiratory rate, maybe an arterial blood gas, ABG, if it's very severe.
And when can someone go home?
Discharge criteria usually include symptoms being well controlled, PEF back up to over, say, 75–80% of their predicted or best, and stable for maybe an hour after treatment.
Okay. What are the official guidelines, like NICE in the UK? How do they approach diagnosis formally?
NICE emphasizes using objective tests. They highlight phenofractional exhaled nitric oxide, which measures airway inflammation.
Pheno, right.
And spirometry with bronchodilator reversibility, BDR, plus monitoring peak flow variability. The approach depends on age.
How so?
For adults, 17 and over, they look at symptoms, maybe occupational links, then do spirometry with BDR and also pheno. For children aged 5 to 16, it's primarily spirometry with BDR first, then pheno if spirometry is tricky or BDR is negative, but you still suspect asthma.
And under 5s?
Under 5s, it's much harder to do these tests reliably, so it's largely based on clinical judgment, symptom patterns, and response to treatment trials.
Okay, are there specific numbers for these tests?
Yes. For pheno, a level of 40 parts per billion or more in adults or 35 or more in children is considered positive, supporting asthma. For spirometry, that FEV1-FVC ratio, less than 70%, indicates obstruction. And for reversibility, it's that 12% or greater improvement in FEV1 after the bronchodilator.
Clear targets.
The overall diagnostic picture still involves that history of recurrent variable symptoms, wheeze, cough, breathlessness, chest tightness, ideally observed wheeze, personal or family history of atopy, and importantly, no clinical features pointing to an alternative diagnosis.
What if the tests are done when someone feels fine?
That's a key point. Tests are more likely to be positive if done when the person is symptomatic. If they're normal when asymptomatic, it doesn't rule out asthma. Sometimes monitoring peak flow variability over 2 or 4 weeks, or repeating tests when symptomatic is needed.
And if it looks highly likely based on history?
If the probability is high, NOIAC suggests starting treatment usually in inhaled corticosteroid, ICS, and seeing if the symptoms improve. A good response supports the diagnosis. Poor response means you need to reconsider other diagnoses.
Makes sense. Let's just quickly revisit those main tests. Peak flow.
Peak flow simple, good for monitoring trends, self-management. Less reliable for initial diagnosis, especially in kids under 5. You're looking for variability, comparing it to personal best using a diary. A big improvement after a reliever inhaler, maybe over 60 Elbin, is suggestive of reversibility.
Spirometry.
Spirometry is preferred for showing obstruction initially. It might be normal between attacks, remember. It's the gold standard for confirming reversibility. Nessie mentions looking for a large improvement, maybe over 400 millilux in FEV1 as strongly suggested.
Pheno.
Pheno measures eosinophilic airway inflammation via nitric oxide in the breath. NICE recommends it routinely now. Other guidelines like SIG and BTS see it as more optional or supplementary.
And chest x-ray?
Usually normal.
Yeah.
Mainly done if you suspect something else: pneumonia, heart failure, foreign body, structural lung problem. Not routine for typical asthma diagnosis.
Okay, diagnosis sorted. How is asthma actually managed long-term?
The main goal is control. Control symptoms, prevent flare-ups or exacerbations, keep lung function as good as possible, and do all this with minimal side effects from medication. It's typically a stepwise approach. You step up treatment if needed, step down if possible.
Before meds, what about non-drug approaches?
Crucial. Identifying and avoiding triggers where possible. Regular monitoring, often with home peak flow. Patient education is massive. Understanding the condition, knowing how to use inhalers correctly.
Inhaler techniques.
Absolutely vital. And having a written, personalized asthma action plan so the patient knows what to do if symptoms worsen.
Okay. Then the medications. The stepwise approach.
Yeah, the UK guidelines follow steps. Step 1 is usually just a short-acting beta agonist, a SABA or reliever inhaler like salbutamol, used only when needed for symptoms.
The blue inhaler.
Often, yes. Step 2, if needing the reliever frequently, is adding a regular low-dose inhaled corticosteroid, an ICS or preventer. This tackles the underlying inflammation.
Okay, preventative step.
Step 3 involves adding another drug, often a long-acting beta agonist, a LABA, usually in a combination inhaler with the ICS. An alternative add-on is an LTRA, a leukotriene receptor antagonist tablet. Some people use MART maintenance and reliever therapy with specific combination inhalers.
Smart.
Yeah, using one combination inhaler, both regularly as a preventer and as needed as a reliever. Steps 4 and 5 involve increasing the ICS dose, adding other agents like LAMA, long-acting muscarinic antagonists, or considering specialist treatments for severe asthma.
Right, escalating therapy.
And again, stressing correct inhaler technique and often using a spacer device, especially with steroid inhalers, is key for effectiveness and reducing side effects.
What about exercise-induced asthma?
Usually managed well with regular ICS therapy. Sometimes taking the reliever inhaler shortly before exercise helps prevent symptoms.
And the specialist drugs for severe cases.
For very severe, uncontrolled allergic or eosinophilic asthma, there are biologic therapies like omalizumab or tezepelumab given by injection. These are managed by respiratory specialists.
Okay, and regular checkups.
Essential. An annual asthma review is recommended for everyone. Check symptom control, lung function, any exacerbations, inhaler technique again, adherence to meds, review the action plan.
And stepping down treatment.
Yes, if asthma is well controlled for about 3 months, guidelines suggest considering stepping down treatment carefully to find the lowest effective dose.
Good. And after an acute attack, discharge criteria.
Similar to before stable on discharge meds, inhaler technique checked and correct, PEF ideally above 75% of predicted or best, and crucial follow-up arranged.
Okay, management covered. What's the general outlook, the prognosis?
Generally, it's good. With proper management, most people with asthma can lead full, active lives. Severe, poorly controlled cases are more challenging, obviously.
Are there factors that predict if childhood wheeze will persist?
Yes, some pointers. Wheezing starting after age 2. Being male, at least before puberty, having frequent or severe episodes, having personal or family history of atopy, and having abnormal lung function early on.
And that hygiene hypothesis.
Yeah, the idea that less exposure to microbes early in life might predispose to allergic diseases. It's complex, but the thinking is shifting towards the importance of a balanced immune response rather than just hygiene. Promoting breastfeeding and definitely advising parents to stop smoking remain key recommendations.
Makes sense. Finally, are there potential complications of asthma?
Yes. The most obvious is severe exacerbations needing hospitalization. People with asthma are also more prone to respiratory infections.
Boy.
If asthma is poorly controlled long-term, there can be some permanent lung damage or airway remodeling. And sadly, death from asthma still occurs, often due to under-recognition of severity, delays in seeking help, or inadequate treatment. You mentioned the UK 2017 stat earlier, 1,484 deaths. It's why primary care practices often maintain at-risk asthma registers to focus care on those most vulnerable.
A serious reminder. So wrapping up, the key takeaway seems to be asthma is chronic, variable, but very manageable with the right approach.
Yeah. Absolutely. Proactive diagnosis using history and objective tests, understanding triggers, consistent management with education and appropriate medication, and regular monitoring. That's the path to good control.
Fantastic overview. Thanks so much. And for you, the learner wanting to really nail this for your exams, don't forget to check out passthemsra.com and also freemsra.com for more high-yield resources.
Definitely worth a look.
Thanks for joining us on The Deep Dive.